Community-acquired pneumonia, or CAP, is a common and potentially serious illness. It is often associated with considerable morbidity and mortality, particularly in older adult patients and those with significant comorbidities. Now, there are approximately 5 to 6 million cases in the United States, among whom approximately 1 million require admission to the hospital for best care. So treatment of CAP in adults in the outpatient setting will be reviewed here. Applying good antimicrobial stewardship principles will provide best care for our patients. The diagnosis of CAP should be established before empiric therapy is started. The presence of an infiltrate on plain chest X-ray is considered the gold standard for diagnosing pneumonia when clinical, and in some cases microbiologic features are supportive. A chest X-ray should be obtained in patients with suspected pneumonia when possible, since clinical manifestations alone are not reliably predictive of pneumonia versus acute bronchitis, which is overwhelmingly due to viral causes for which antibacterial agents are not warranted. Determination of whether a patient with CAP can be safely treated as an outpatient or requires hospitalization is essential before considering further diagnostic testing and selection of an antibiotic regimen. Severity of illness is the most critical factor in making this determination, but other factors should also be taken into account, and these include ability to maintain oral intake, likelihood of compliance, and patient functional status, as well as oxygenation status. Prediction rules have been developed to assist in the decision of site of care for CAP. The two most commonly used prediction rules are the Pneumonia Severity Index, or PSI, and CURB 65. The PSI is better studied and validated, but requires a more complicated assessment and assesses up to 19 variables. The CURB 65 uses 5 prognostic variables, so is simpler to assess and therefore preferred by many in ambulatory practice. Now, the variables for CURB 65 are as follows. C is confusion associated with pneumonia. U is urea, or a history of renal disorder, or a BUN greater than 20 milligrams per percent. R is respiratory rate greater than 30. And B is blood pressure, which is systolic less than 90 or diastolic less than 60, and then age greater than or equal to 65 years. It's suggested that patients with a CURB 65 score of 0 to 1 are at low risk and can likely be treated as outpatients, and those with a score of 2 or greater should be admitted to the hospital. Empiric treatment regimens for outpatients with CAP are based upon the presence of comorbid conditions and the prevalence of risk factors for drug-resistant Streptococcus pneumoniae. For patients who are healthy without recent antibiotic use, antibiotic selection depends upon the local prevalence of macrolide resistance among Streptococcus pneumoniae isolates. Now, the overall prevalence of macrolide-resistant pneumococcus, both high and low level, in the U.S. now exceeds 40%. Therefore, I recommend that a macrolide not be used as empiric monotherapy. I believe doxycycline remains an effective monotherapy regimen if the rate of resistant pneumococcus is less than 25% in one's community. Now, the risk of resistant pathogens is higher in patients who have had major comorbidities or recent antibiotic use. For such patients, combination therapy with a beta-lactam plus a macrolide or a respiratory fluoroquinolone is recommended. However, the greater convenience of fluoroquinolone monotherapy must be balanced against the severity of adverse effects, including the risk for C. difficile infection and the risk of selection for resistance in colonizing organisms, which are generally thought to be greater with the fluoroquinolones. As far as duration, most ambulatory patients with CAP should be treated for 5 days. Several recent studies have demonstrated similar outcomes with less than 7 days versus greater than 7 days of antimicrobial therapy. Reducing to the appropriate duration of antimicrobial therapy is good antimicrobial stewardship. Patients should be afebrile for 48 hours and clinically stable before therapy is discontinued. Most patients with CAP begin to improve soon after the initiation of appropriate antimicrobial therapy, as evidenced by resolution of symptoms, physical findings, and laboratory signs of active infection. However, some symptoms often persist as the patient convalesces, and at least one symptom, such as cough, fever, or dyspnea, is still present at 28 days in many patients. All patients with community-acquired pneumonia should be appropriately vaccinated for influenza and pneumococcal infection. And screening for influenza vaccination status is warranted during the influenza season, such as from October through March in the Northern Hemisphere, in all patients. In addition, smoking cessation should be a goal for patients with CAP who smoke.